He may even identify himself with it and believe that he is what he appears to be.
Welcome to the NCE Study Guide. I created this study guide using ChatGPT and Notebook LM. So think of these modules as AI-powered audio flashcards. Each one of these 20 modules contains 10 mock questions representing the kind of questions that you might encounter on the National Counseling Exam. I created this primarily for myself, and I decided to make these available to anyone else who might benefit from this kind of study aid. But please note, while I have done my best to ensure that these modules align with NCE content, I encourage you to cross-reference them with trusted study guides and resources for the most accurate preparation. These modules are not affiliated with or endorsed by the NBCC or any official licensing board. And today I'm introducing a new case study module. Now, as you may already know, I took the NCE and I passed it a few weeks ago, but I learned so much from putting these modules together, and I enjoy seeing the downloads increase and hearing from listeners who reach out. So I've decided to take this case study approach to kind of bridge that gap between prepping for the NCE and really getting started as a mental health care professional in the field, really understanding the ethics and the different modalities and the interventions and how would I do a diagnosis for certain situations. So that's what you're going to be hearing in these case study modules. And I also want to remind you that I'm putting together a grassroots study group for anyone who is looking for some real life person interaction as you prep for the NCE, not just these AI puppet shows. So if you're interested, email me at ncestudyguide@gmail.com. So, with no further ado, here are your AI study buddies from Notebook LM. Enjoy.
Nice to be in orbit.
Welcome back, everyone. So let's dive right in. This is Case Study Module 5, number 5 out of 10, really designed to help you get ready for the NCE.
Exactly. We're taking a specific case study today and, pulling out the key things you need to know, making it practical for your prep.
And this is all based on the NCE Study Guide. It's put together by Glenn Osland. Interesting background here. He actually passed the NCE himself.
Yeah, so he knows what it takes. Plus, he's got master's degrees in both folklore and clinical mental health counseling. And he's been podcasting, since 2010?
That's right. A long time.
Yeah.
So he knows how to break things down. This guide, it's basically a series of research-backed modules. The focus is really on applying the concepts.
Right. Not just memorizing stuff, but seeing how it works in practice.
And the way he builds these is kind of cool. He calls it his AI puppet show. Basically, he starts with ChatGPT for some initial drafts, digging into theory and ethics, then refines it in Google Docs, and then uses this AI tool, Notebook LM, to sort of synthesize it all and explore different angles based on his own instructions.
So it's this layered process using AI for the heavy lifting initially, then his expertise refines it.
Exactly. And what you get is this dialogue, kind of like what we're doing now, that mimics the critical thinking you need for the NCE.
Yeah.
Seeing how all the pieces fit,
It allows for a really thorough look at the material from different sides.
Now, if this is helpful for you, Glenn actually runs a weekly study group for listeners. Could be really useful.
Definitely. Learning with others, sharing insights, asking questions, it makes a big difference.
Yeah, so if you want to join, just shoot an email over to ncestudyguide@gmail.com. They'll give you the info.
Good resource to have.
And also, look, we want these deep dives to hit what you need for the NCE. So if you have ideas for future case studies or, specific counseling issues you want us to cover,
please send them in. Yeah, your input really helps us focus these modules where they're needed most.
Absolutely. Okay, so today's focus, Case Study 005. It's called Elena, the Survivor. We're going to be looking closely at ethical decisions, different theoretical approaches, and, initial treatment planning ideas, all key NCE stuff.
This case really lets us unpack those interconnected areas. It's a good one for NCE prep.
So let's meet Elena. She's 24, Latina, and she's coming into counseling about 2 months after a sexual assault by a coworker.
Okay. 2 months post-incident?
Yeah, and she's experiencing some really tough symptoms. Nightmares, flashbacks. She's hypervigilant, finding it hard to concentrate at work.
Classic trauma responses. The re-experiencing, the hyper-arousal.
Right, and she's pulling back socially, too. Avoiding events, struggling with trust. She described feeling disconnected from her body.
That sense of disconnection or dissociation is really common after trauma like this. It's a significant symptom.
And it took her a while to even seek therapy. She mentioned feeling shame, being afraid people wouldn't believe her, worried about her family's reaction.
Understandable hesitations, shame, fear of disbelief, cultural factors. These are real barriers for survivors.
Yeah. She says she feels like she's lost herself. This is actually her first time ever in therapy.
Okay, so that first interaction is crucial. Building that safety and trust right from the start.
Looking at her history, no previous psychiatric issues. She comes from a close-knit immigrant family, strong Catholic values.
Important context there.
And in her family, expressing emotions wasn't really common. And things like trauma or mental health, they just weren't discussed much.
That family dynamic, the cultural norms around emotional expression, that's definitely going to influence how she processes this.
Currently, no active suicidal thoughts, but she did mention sometimes having these passive thoughts like wishing she could just disappear.
That points to significant distress, even without immediate risk, a desire to escape the pain.
She's working full-time, lives on her own. Okay, so that's the picture. Let's get to section 1, ethical considerations. This lines up directly with the NCE's ethics and multicultural competence domain.
Right, foundational stuff.
First up, informed consent and emotional safety. We absolutely have to be clear about her rights, confidentiality, the limits and what trauma therapy actually involves.
Absolutely critical, especially with trauma. She needs to feel safe, informed, and, crucially, in control of the process. Transparency builds trust.
Then there's B, cultural sensitivity.
Right.
We really need to think about how her Latina background, family honor, shame, gender roles, how all that might be shaping her experience.
Yes, we need to understand her cultural lens, not impose our own. How does her background influence her understanding of the assault, her willingness to talk, her sources of strength? Cultural humility is key.
And C is trauma-informed practice. Basically, avoid anything that could re-traumatize or pathologize her. It means going at her pace, always prioritizing her consent for any intervention.
It's a lens for everything we do. Recognizing the impact of trauma, creating safety, empowering the client. It's not just one technique, it's an overall approach.
Lastly, for ethics, mandatory reporting. We need to check, is there ongoing danger? Was the perpetrator a minor? Reporting laws vary, so we need to know the local requirements.
Right. In Elena's case, assault was 2 months ago. Adult coworker, no immediate danger mentioned. Reporting might not be legally required here, but we still need to discuss her options for reporting if she chooses to, and support her decision. It's about her agency, too.
Okay, good points. Let's move to section 2, assessment and diagnosis. This maps onto NCE areas like appraisal, diagnosis, social foundations.
Getting a clear picture.
So assessment tools, the PCL-5, the PTSD checklist comes up first. It's a self-report, matches the DSM-5 criteria for PTSD.
Standard tool for PTSD. Very useful.
Also the Beck Depression Inventory, the BDI-2. Good for checking depressive symptoms, right? Since that often co-occurs.
Exactly. Comorbidity is common with trauma, so assessing for depression is important.
And of course, a detailed trauma history interview, getting the timeline, triggers, any dissociation.
Yeah, the interview really fleshes out her specific experience, how it's impacting her day-to-day life.
So based on what we know, the most likely primary diagnosis, according to the DSM-5's TR.
Well, given the symptoms, re-experiencing, avoidance, hyperarousal, negative mood changes, and the fact it's been 2 months.
Right, longer than a month, so not acute stress disorder.
Correct. Acute stress disorder is ruled out by the duration. PTSD seems the most likely primary diagnosis.
Post-traumatic stress disorder.
Okay.
And we'd also keep major depressive disorder in mind as a possible co-occurring thing.
Definitely. Need to assess for that, too. It can affect presentation and treatment.
And just recapping her PTSD symptoms. Re-experiencing, we see nightmares, flashbacks,
Check.
avoidance, social withdrawal, that emotional numbing she mentioned,
Check.
arousal, hypervigilance, trouble concentrating,
Check.
and negative thoughts, mood, shame, feeling disconnected, losing herself.
Yeah, that all lines up very clearly with the PTSD criteria in the DSM-5 TR.
Okay, section 3 then, theoretical approaches. Connects to NCE theories and cultural foundations. 3 main ones highlighted here. First, TF-CBT, trauma-focused cognitive behavioral therapy.
Right. A very common evidence-based approach for PTSD.
And the reason? It directly targets those unhelpful thoughts and beliefs about the trauma, and it helps build coping skills.
Exactly. It integrates cognitive restructuring, changing those negative thought patterns with behavioral strategies like exposure to reduce avoidance and anxiety. Strong research backing.
Second approach listed is EMDR, eye movement desensitization and reprocessing.
another well-established trauma therapy.
This one uses bilateral stimulation, like eye movements, right, to help process those stuck trauma memories.
That's the core mechanism, yes. The idea is that the bilateral stimulation helps the brain reprocess distressing memories so they become less emotionally charged, more integrated. It accesses the memory network differently.
Okay, and third, critically, multicultural counseling.
Absolutely essential here.
Given Elena's background, Latina, Catholic, the family dynamics we talked about, we have to tune into that cultural context, understand her values, maybe spiritual conflicts, and see how we can integrate cultural healing practices if that feels right for her.
Yes, it's not just an add-on. It should permeate the entire approach. How does her culture inform her experience of shame or help-seeking behavior, her sources of resilience? We need to ask, listen, and adapt our approach respectfully.
Okay, that makes sense. So Section 4, interventions. This hits the NCE's helping relationships in trauma work areas. Let's talk phases. Early phase.
Safety and stabilization first, always, before digging deep into the trauma itself.
So things like teaching grounding techniques for when she feels overwhelmed, mindfulness, sleep hygiene.
Exactly. Practical skills to help her manage the immediate distress and regulate her nervous system, building a foundation of safety in her own body and in the therapy room.
And psychoeducation too, right? Explaining PTSD, normalizing her reactions.
Huge. It reduces shame, helps her understand why she's feeling this way. It's not her fault. It's a reaction to trauma. And maybe, if she's ready, starting to gently map out a timeline of the trauma narrative. But only when she feels safe enough.
Okay, then middle phase. If we're using TF-CBT, this is where we challenge those distorted beliefs like, it was my fault or I'm broken.
Yes, the cognitive restructuring piece becomes more central, helping her examine the evidence for and against those thoughts, developing more balanced perspectives.
And if she's stable and ready, maybe starting EMDR processing.
Potentially, yes. If she meets the criteria for readiness sufficient coping skills, stability EMDR could be introduced to process the specific traumatic memories.
And throughout this, we'd keep weaving in those cultural or spiritual coping strategies that resonate with her, like rituals, journaling, exploring family meaning.
Absolutely. Those can be powerful resources for healing that are grounded in her own worldview. It's about integrating all aspects of her experience.
Some specific psychoeducation topics mentioned. Trauma and the nervous system. Fight, flight, freeze.
Yeah, explaining the biology can be incredibly depathologizing, understanding how the body reacts to threat.
And also culturally specific responses to trauma and healing.
Right. Acknowledging that different cultures have different ways of understanding and coping with traumatic experiences.
Yeah.
Validating her specific cultural context.
How do we know if things are progressing? What are the indicators?
Well, you'd look for objective things like a lower score on the PCL-5.
Okay.
And subjective reports, fewer nightmares, less hypervigilance. Also, seeing her use coping skills more effectively, better emotional regulation, and, importantly, shifts in those negative beliefs, more self-compassion, less shame.
Got it. Tangible changes.
Okay.
Section 5, key takeaways for the NCE. Boiling it down.
Yep. The essentials from this case.
So, using trauma-informed ethics is key. Picking the right assessments, like the PCL-5, BDI-2, knowing the evidence-based treatments, TF-CBT, EMDR.
Crucial.
Being culturally sensitive, integrating her worldview,
Non-negotiable.
and remembering pacing, client empowerment, stabilization first.
Foundational trauma principles.
And finally, always think about differential diagnoses and potential comorbidities in trauma cases.
Right. Don't just stop at PTSD. Consider the whole picture. These takeaways really hit the core competencies tested on the NCE. Applying them to Elena makes them stick.
Definitely. Okay, let's test that understanding. Section 6, NCE-style review questions. You've got 10 multiple choice questions. Ready?
Let's do it. Good practice.
Question 1. Based on Elena's reported symptoms and the timeline following the sexual assault, what is the most likely primary diagnosis according to the DSM-5-TR? Your options are A, acute stress disorder, B, major depressive disorder, C, post-traumatic stress disorder, D, adjustment disorder with depressed mood.
Okay, so thinking back, symptoms present for 2 months includes re-experiencing, avoidance, hyperarousal, negative mood shifts.
Right, which rules out A, acute stress disorder, because that's under a month. B and D don't fully capture the trauma-specific symptoms.
So it really points strongly to C.
Correct. C, post-traumatic stress disorder. The duration and the specific symptom clusters fit PTSD criteria.
Makes sense.
Question 2. Which of the following is the most appropriate trauma-focused assessment tool to utilize in the initial assessment with Elena? A, MMPI-2, B, PCL-5, CBAC Anxiety Inventory, BAI, D, Trauma Symptom Checklist for Children. TSCC.
MMPI-2 is broad personality. BAI is just anxiety. TSCC is for kids.
Exactly. So the most direct measure for her suspected PTSD symptoms is?
Has to be B, the PCL-5.
That's it. B, PTSD checklist for DSM-5, PCL-5. It's designed specifically for assessing DSM-5 PTSD criteria in adults.
Good. Next.
Question 3. In adhering to a trauma-informed approach when beginning therapy with Elena, which action would be most important for the counselor to prioritize? A, immediately explore the assault details. B, rapidly reprocess memories. C, prioritize safety and empowerment. D is relevant later, given an attachment history.
Okay, trauma-informed priority at the beginning. A and B sound premature, potentially destabilizing. D is relevant later, maybe, but not the first step.
Right. The foundation of trauma-informed care is?
Safety. C, establish safety and empower her.
Correct. C, prioritize establishing emotional safety and fostering a sense of empowerment for Elena. That comes first.
Absolutely.
Question 4. Which therapeutic modality uses bilateral stimulation, like eye movements, to process traumatic memories? A, narrative therapy. B, EMDR. C, existential therapy. D, solution-focused brief therapy. SFBT.
Bilateral stimulation. That's the
Yeah.
defining feature.
B, right. Yeah, EMDR.
Correct. B, eye movement desensitization and reprocessing. EMDR.
Straightforward one.
Question 5. Given Elena's Latina cultural background and Catholic values, what's an ethically responsible action? A, encourage her to challenge beliefs hindering recovery. B, avoid discussing culture spirituality to stay neutral. C, explore how culture spirituality can be a support. D, recommend she focus on religious leaders instead of therapy.
Okay, ethics and culture. A, feels dismissive. B, ignores a huge part of her identity. D, undermines therapy. C sounds like the most respectful and potentially helpful approach. Exactly. We want to integrate, not dismiss or replace.
Yeah.
So, actively explore how Elena's cultural values and spiritual beliefs might serve as sources of strength and support in her healing process.
Ethical and effective.
Question 6. What's a positive indicator of progress for Elena in the middle phase of treatment? A, increased avoidance. B, intense guilt, self-blame. C, increased ability to use grounding, self-soothing skills. D, complete suppression of trauma memories.
Progress. A and B are signs of worsening symptoms or distress. D isn't the goal of trauma therapy. Integration is. C shows she's developing coping skills.
Right. She's learning to manage the distress. So,
Yeah.
C, her increased ability to utilize grounding techniques and self-soothing strategies when experiencing flashbacks or intrusive thoughts, that shows improved regulation.
Clear sign of progress.
Question 7. What's a potential cultural barrier Elena might face? A, over-identifying with therapist. B, cultural emphasis on stoicism stigma about discussing struggle outside family. C, excessive reliance on mindfulness to avoid emotions. D, lack of available social support.
Thinking about her background, close-knit family, emotions not openly discussed. B seems very relevant. That cultural pressure to keep things private, the potential shame.
Yeah, that aligns with what we discussed earlier. A could happen anywhere. C is misuse of a tool. D might or might not be true. So, B, a cultural emphasis on stoicism and the potential stigma associated with discussing personal struggles outside the family. That's a common cultural barrier.
Makes sense in this context.
Question 8. Which psychoeducation topic would likely be most relevant and helpful for Elena? A, Jungian archetypes. B, fight, flight, freeze response explanation. C, detailed criteria for borderline personality disorder. D, encouraging suppression of negative thoughts.
We want psychoeducation that normalizes her experience. A is too abstract. C is irrelevant and potentially stigmatizing. D is countertherapeutic. B directly addresses her hypervigilance and avoidance.
Exactly. Normalizing the body's response. So B, a clear explanation of the fight, flight, freeze response and how it relates to her current experiences of hypervigilance and avoidance.
Very helpful for reducing self-blame.
Question 9. A primary goal of TF-CBT with Elena would be to A, erase all trauma memories. B, teach complete emotional suppression. C, help reframe maladaptive beliefs and build coping skills. D, interpret unconscious conflicts.
TF-CBT core principles. It's not about erasing or suppressing, A and B. D sounds more psychodynamic. C hits the main components, cognitive restructuring and skills building.
Right on. C, help her to identify and reframe maladaptive trauma-related beliefs and develop more effective coping skills. That's the heart of TF-CBT. Last one, question 10. When initially discussing potential trauma-focused interventions with Elena, which ethical principle is paramount? A. Addressing therapist countertransference. B. Avoiding paternalism by making decisions for her. C. Obtaining informed consent, understanding risks, benefits. D. Avoiding dual relationships.
Okay, initial discussion of interventions. A is the therapist's work. B is unethical itself. D is important generally, but C, informed consent, is absolutely crucial before starting potentially intense trauma work. She needs to know what she's agreeing to.
Absolutely. The foundation for ethical treatment. C. Obtaining Elena's informed consent, ensuring she understands the nature, potential risks, and benefits of the proposed interventions.
Can't proceed without it.
Yeah. Okay. That was a good run through. So you made it through case study module 5. We covered a lot. Ethics, assessment, diagnosis, theories, interventions, all tailored for that NCE mindset.
Yeah, Elena's case really brings together so many key elements. Trauma-informed care, cultural competence, ethical practice. These are themes you'll definitely see on the exam.
And remember, if you want to keep discussing this stuff with others preparing for the NCE, check out Glenn's weekly study group. Email nceststudyguide@gmail.com for info.
Great opportunity for collaborative learning.
And please keep sending us your ideas for future deep dives. What cases, what topics would help you most? We really rely on that input.
Absolutely. It helps us make these as useful as possible for you.
So as you wrap up today and keep studying, here's something to chew on. Reflect on how working through a case like Elena's, integrating all these different pieces, the clinical, the cultural, the ethical, sharpens your critical thinking. How does that practice prepare you not just for the NCE, but for the complexities you'll face as a counselor?
2, 3.
Nice to be in orbit.